Thank you for the invitation, and I'll just quickly run through this. Like I said, I was with Ramesh, Ramesh, and we were just talking that maybe around 15 years back, he used to send a patient all the way from Cochin to Coimbatore to get somebody embolized because at that time there was nobody to do it here. Just to show that it is a useful procedure, and today we got people all around doing it, and I think it's fantastic to see the response and the acceptability that these are procedures that can make a difference in the life of a patient. So GI bleeding continues to be a medical emergency, we know that, and often needs support of medical, surgical, interventional radiology services, and it can be arterial or it can come to the portal venous system, and we'll be talking more about the arterial this forenoon. So when would you actually think of calling an interventional radiologist to do a procedure? One, when there's massive bleeding. The problem is at times you cannot really locate where this bleeding is coming from. Also in this group comes patients with a very low hemoglobin, where you may also have a problem again locating a bleeding vessel. Then bleeding from the small bowel, even with the double endoscope, balloon endoscopy, why it is difficult. And this is one place where all the bulk of the patients we do are actually bleeding from the small bowel. Then in hemophilia, conditions where the bleeding comes not directly into the bowel, but it comes via a system like the biliary duct again, and interventional radiology is probably the only way that you could really go in and treat it. Then in bleeding from a tumor, there's a huge advantage. You actually palliate the patient, or actually you stabilize the patient and then send him for surgery, which can change. And of course, the other one that I didn't mention is when endoscopic techniques fail. And that's also a cluster of patients where they for some reason or the other do not respond. So whenever we get a patient with bleeding, this huge big question that comes to your mind is where exactly is the bleed coming from? And the second, what is the reason they bleed? This why is important, because do we stop with embolization, or would you say now go ahead and resect the segment of the bowel, because otherwise the patient will continue to bleed? The biggest thing that has happened for us is we get both these answers today from a multi-slice CT. And to us actually this multi-slice CT has been a revolution in the management of GI bleeding. For example, here is a patient in the ileum with a polyp who's bleeding. The CT shows the active bleeding, it shows the cause of the bleeding, and also we have this huge advantage today that it actually maps the vascular anatomy. So, for us today to embolize a bleeder would not take more than 30 minutes, because we know the vessel, we know the hardware that's going to be necessary. Whether we see a bleeder or not, an angio does not matter. Often we get a patient who actually had an endoscopy done, there will be a lot of gas, and it will be extremely difficult to actually locate this bleeder in a patient who is actively bleeding and who is sick. So CT has really been the cornerstone that has changed the way we approach. So in other words, CT has actually changed the way we approach GI bleeding. We no longer ever do angiography to locate bleeders. Why is the CT the one-stop shop for us? It locates bleeding. It's very, very sensitive, more sensitive than angiography, especially in a patient with bowel gas or a distended bowel. It locates the cause very often. I mean, may not be in sometime when it's just an ulcer, but otherwise it's a tumor or a diverticular, or it's not hampered by gas. It demonstrates the vascular anatomy, which makes a big difference for us. Sometimes we'd come from a brachial route just by looking at the anatomy. We know the kind of material we require. And today we limit TSA just for treatment only. So what are the treatment options? We would embolize arterial bleeds. We had this talk with Venkat telling us about tips that's used for portal hypertension, and BRTO. These are the armamentarium that we do, but the bulk of the work today, even today, continues to be embolization. So, and that's the role in arterial bleeders. Now, before CT came, we would actually do this whole thing. We would map every vessel, that is, we do a celiac axis shot, selective gastroduodenal shot, then the SMA shots, and with power injections, and we locate a bleeder like this out here, you can see, and then we would take a catheter and a microcatheter, and finally we would embolize them by using this. I mean, this microcatheter is another device that's made a huge difference for us. These are small little catheters that go inside a diagnostic catheter. And so we are able to go far more distally, and in this case, for example, this is the diagnostic catheters that we routinely use, through which these microcatheters go, and then we would inject them rarely with PVA. In this case, we use PVA. This is PVA polyvinyl alcohol sponge. We use particles around 300 microns, provided it's an extremely vascular territory like the duodenum or the ileum. We would not use it for the colon because the tendency for ischemia is high. We did not reduce the particle size to less than 300 because, again, ischemia is high. And just to show that how it's done. But what's the advantage of a CT? Here is a patient again who's come with recurrent bleed. We do a CT. We actually can see this cluster of abnormal vessels out here. We know this is an AV malformation. This is a patient who is hypotensive, who's bleeding severely, and then the CT actually helps us. And now we can go in, we can actually inject particles out here, stabilize the patient, but we also tell the patient and whoever is referred to us that the treatment doesn't end here and has to go for an elective resection of the bowel, because an AVM will recur unless we use something like glue, and if you're going to use glue, the bowel is going to infarct. So that's the advantage of CT, the difference that we can decide. Here's a look at this patient who came to us with a stab injury and in hypovolemic shock. How do you know the patient is in hypovolemic shock? You can see the IVC completely collapsed. They were trying to resuscitate the patient, they couldn't resuscitate. CT shows the bleeding at the jejunal level. Angiography, and actually this is a single slice CT, an old picture, shows this active bleeding, and you can technically go right up to the vessel that's bleeding and block it and send the patient for surgery. And this lady, she survived. Actually, it's one day before a marriage, and some thieves had decided that she's got a lot of jewels at home and tried to stab her, but she went home alive. But traditionally, when we work with the bowel, the embolic agent we use is coils. Actually, coils have been used in radiology for more than 25 years, invented by Giantrico. And today, like you said, it's for the first time I realized you'll do it, even you started using it through the endoscope. Now, what one has to understand when we work with a gastroduodenal arcade, we take a diagnostic catheter, take a microcatheter through it, go distally beyond the point of bleed, put coils out here, and then across it. The reason that if you do not trap the aneurysm, it will reform again through collateral pathways, and this is a mandatory thing to be done. Here is another case, a CT. We can see one small little bleed out here, and we take a second scan and a third scan. You can see it progressively increasing. By the time we do the angiogram, we do not see active bleeding. But the advantage of CT is you can actually map the vessel, enter the vessel super selectively, and you can actually block it. Now we put these coils. And now with this we stabilize the patient, we stop the bleeding of the patient, but there is another huge advantage. The huge advantage comes for the surgeon. Like in our center, we always tell the surgeon, we put a coil and he uses a C-arm today to locate the segment which the artery supplies, and he can resect it, being absolutely certain that this is a segment that has to come out. It's like the old days where you put a catheter and put methylene blue. So we do it very often for the surgeon. We just tell, look, even if I use a little particle, I put one little coil and say, look, have a look at it with the C-arm, and you can be very sure of it. So these are these coils, how they look like. They actually come in a cartridge-like device which is straighten it, we push it or we inject it, and we block these vessels. Here is a patient who comes with excruciating pain in the abdomen, and there is a Doppler BP. We do a CT scan, and if you look at the CT closely, we realize there is a small pseudoaneurysm out here. Now when we do an angiogram, you can when we do a DSA, you can completely miss the finding. But because of CT, we know that the pathology is here, we know there is a segment which is eroded out here, and this is the point which has been bleeding into a large pseudocyst, and you can go inside and coil this successfully and being absolutely certain that this patient is fine. This is an injection after the coiling into the SMA to show that retrograde collaterals do not reopen this. There's a case in which where we actually found retrograde filling, and if you do not treat it completely, you can get into a problem. Let's look at some unusual cases. Here is a patient who came with massive hematemesis to us. The CT, the endoscopy showed there was an erosion and a huge kind of indentation. We do a CT. This is a massive aneurysm. There is a huge aneurysm coming from the splenic artery. Sorry. Now, you can see this very, very tortuous splenic artery. This is a calcified segment out here. We do the DSA. You can see it's impossible to take a main catheter out here. And so we take a micro catheter. I'm so sorry, I keep going to the next slide without thinking. Okay. And this is the micro catheter. This has come right into this. You can see part of the aneurysm which is still filling. Part of it is thrombosed, it's calcified, it's chronic. You know, the problem, the safest thing is to put coils out here. So we attempt coils, and what happens is the coils would just fly off. Have a look at this. So what would we do? In this we use cyanoacrylate glue. Technically a little more challenging. You can see the glue cast exactly in the vessel. It's important when you use this glue that the neck of it is completely gone, and to ensure that retrograde collateralization doesn't take place. Here is the glue cast, and after that look at the CT. The CT shows a fully thrombosed aneurysm. It's a life-saving procedure. There's no other way one could really think of even handling such cases, just to show the amount of things that's today possible through a catheter. You know, its daughter in 1964, he said, used to the imagination, a diagnostic catheter can become the most powerful surgical tool. And you always imagine, it's amazing, somebody 50 years ago could predict something as amazing as this. Here's another case with a patient pancreatitis. And the advantage, like I said, today with the modern CTs, you can map the vessel, you can see it, you can see this huge pseudoaneurysm out here. You know what to do, you know what the vessels to take, you know it's arising from the celiac axis, and you go in and you see the absolute depiction of exactly what you saw. So we have the catheter, we cross it, and this is what I said of learning to trap it well, making sure that both distal and proximal you have your coil. If you do not do that, there's a chance that you'll find retrograde filling coming from the SMA, and sometimes those access can be very, very difficult and a patient can die. So recurrence when we see is usually because of lack of experience by the operator and not because embolization is bad. Another case very, very similar, just to show you, again a patient, pseudoaneurysm coming from the gastroduodenal artery is a very common association with pancreatitis. And a very, very similar kind of treatment where you have done a trapping, we've taken the catheters both distal and proximal, and then you do the superior mesenteric artery shot. You can see the contrast column coming all the way right up to the arcuate again from the pancreatic branch of the SMA, but because you're taking both proximal and distal, you know this patient is cured and there will be no recurrence. Sometimes you may not use a CT. For example, a case like this, large GI bleed and an endoscopy actually shows a big pulsating vessel under an ulcer which is bleeding torrentially, and there you can see the angio depicts the same thing, a large pseudoaneurysm, and the same thing of going in and blocking it by placing some coils into it. So most of the time we do a CT unless and until there is a situation where you actually can see the bleeding point, and you know that it's not going to respond to an endoscopic procedure, or because it's failed to endoscopy. Let me show you another thing, just to show you that devices have become so good that you can just about reach anywhere. This is a patient who's got a celiac axis occlusion. You can see the retrograde filling of the gastroduodenal artery and the hepatic artery from the SMA injection. What this patient had was an ulcer of the duodenum which is bleeding, which is not responding to multiple endoscopic procedures. We actually could take this microcatheter. You can see it here. The microcatheter is taken from the superior mesenteric artery, looped it around the pancreatic artery, and we bring it all the way up into the site of bleeding right here. I mean, it looks technically challenging, but just to say that, you know, today with the right hardware, the right imaging, access is no longer a big issue, and we can go ahead and treat them successfully. So we actually, that's what we've done. We placed a coil out here and a coil out here across the segment and right into the vessel out here, and it was successfully stopped, and the patient was stabilized and didn't bleed away. Just to say, the sensitivity of CT is much better than that with DSA, though in DSA we say 0.5 ml per second, but in reality it's never true. There is so much of bowel gas, and sometimes the patients are just not cooperative, they wouldn't hold their breath, and in all these situations CT plays an amazing role. where we actually can see little things that, a small point where we see a dense contrast leaking out. We map the vessel like you said, go right there, enter it and coil it. Now, colonic bleeds are not commonly treated. Honestly, it's rare and only comes when it's failed to an endoscopic management. And this is an elderly 87-year-old patient who couldn't tolerate the scope, and because of this he came to us, but we knew it was a colonic bleed and this is it. So you can just go ahead, come into the arcuate and place a coil across it, not even into it, and the head pressure drops and the patient does well. Do we get bleeding from the inferior mesenteric artery? I'll just show an interesting case of a patient with pancreatitis, again with a massive drop in BP. All that the CT shows is this little dot, which shows that the patient has a pseudoaneurysm. That's the greatest thing about CT. If there's somebody to look at the CT carefully, you can pick some amazing finding. Look at this out here. All you see is this dot in the center of the hematoma. We do an inferior mesenteric angiogram and you can see the pseudoaneurysm. The size of the pseudoaneurysm has got absolutely no relevance to the severity of the bleed, because a pseudoaneurysm is just blood twirling inside a clot. So there is more of clot, less is the size of pseudoaneurysm. And again, we can just to show you that the hardware quality is so good that you can actually take this microcatheter, come right into the point of bleed, cross the segment and trap the vessel, and this guy is definitely not going to bleed from that point again. Just to show you this injection out here, the coil out here, an injection from the superior mesenteric artery to show that there is no filling from the right colic artery or the mid colic. Rectal bleeds, again very unusual to come for embolization, but sometimes they do come when they continue to bleed after an endoscopic technique. This was an elderly gentleman. He was having intermittent massive bleeding from the rectum, failed to endoscopy. You can see this bleeding point out here, and the same thing on CT, and you can see on angiography the bleeding from the superior rectal artery out here, actively bleeding. Just enter the vessel, and here you can safely use PV, a very, very vascular area, and they generally respond. Like I said, CT is got an advantage. It picks up tumors, and if somebody is bleeding from a tumor, well, the biggest advantage, this is actually a CA pancreas bleeding, and you can go in and stabilize. Now, this is not an operable case. So, if it's not an operable case, you would just actually stabilize the patient. Otherwise, you would embolize the patient and send him for surgery. And this patient also was from somewhere in Kerala. This is what is embolized, and the surgeon actually sent me the picture. It was the gist that was bleeding, and you stabilize the patient, and you can do a much better surgery when the patient is stable with a much better post-surgical outcome. The commonest post-surgical condition which we get for embolization is, of course, Whipple's, but sometimes we can also get in a lap cholecystectomy where this patient was torrentially bleeding from the drain. This is the angio showing a pseudoaneurysm from the cystic artery at the point of the clip. Again, in this it's important that you cross and do a proximal and a distal embolization. See, you can see the angio shows retrograde collateralization and filling back. You don't do this, you're finished. There's no way that you can access these vessels again. And again, this was a life-saving procedure in a patient who came to us very, very unstable. But like I said, the most common cause of a post-op bleed is actually Whipple's, and you can see the CT, you can see the blowout from the gastroduodenal artery stump and the big hematoma around it. This is the angiogram. It looks so different from the CT, but you know from there that there is a big clot and a pseudoaneurysm here. You enter the vessel and you coil the stump off, and you would have saved this patient's life. Yeah, that's the same thing. And of course the coil mask to show you the SMA shot that we always take to ensure there is nothing. Sometimes you can get some extremely rare condition. For example, this is one of the most dangerous condition, autoenteric fistula. This patient had a surgery for aneurysm sometime in the past and then came to us, and the CT shows this finding where actually you can see contrast extravasating in the bowel, and the bowel wall is thickened. Unless it's really small, even if you treat it successfully, they all die of secondary infection of the graft. But in this case was a very small one, and I can show you, we put a little small covered graft, stent graft out here, and this patient continued to live for several years, again came back with bleeding 4 years later, and this time there was really impossible because the erosions were from another point where we couldn't put a graft. But just a very rare condition which can present with bleeding, and you can try. Of course, we talked about portal hypertension, which can come with bleeding. Let me show an unusual case. This was again referred from us by Dr. Mathew Philip. Huge aneurysmal dilatation of the portal vein secondary to a fistula between the aorta and the portal vein. Here's the sac, and this was treated by placing coils precisely across the neck, which in this case helped. Cause TIPS is a condition that we talked about, and again is still used not just for an emergency, but definitely is very, very relevant when you have a patient who's not responding. The technique I know most of you know, I just described it once again. When you come through the jugular vein, through the hepatic vein, into the portal vein, and then pass it and then dilate this and place a covered stent graft, the Viator from Gore or the equivalent which is made by Niti, which is the only thing that's currently available in the country, and you can have it and you can change the direction of flow and bring down the pressure. For like this in a patient, huge fundal varices, patient bleeding profusely, and this is the procedure, this is the technique, balloon dilatation, stent graft, and you can see the end of it that the varices has disappeared. So that's another thing, extremely expensive, very difficult to convince an Indian patient who's sick. So if you had to conclude, the combination of CT and endovascular procedures can often be the ideal combination that can completely change the outcome of a patient, provided the indications are correct. Thank you.